Hello, friends and colleagues, and welcome to episode 106 of Dermasphere, the podcast by dermatologists, for dermatologists, and for the dermatologically curious. I am one of your hosts. My name is Luke Johnson. I am a pediatric dermatologist and general dermatologist with the University of Utah. And joining me, of course, is...
This is Michelle Tarbox. I'm an associate professor of dermatology and dermatopathology at Texas Tech University Health Sciences Center in beautiful, sunny Lubbock, Texas.
Our mission is to bring you discussions of some of the latest research in the world of clinical dermatology so you can listen to them instead of having to find them yourselves and read them. We also, of course, always have our third member, the Pimping Bell, joining us. The Pimping Bell will ring when it is time to highlight some especially important content, so pay attention. Perhaps I became a doctor to treat people's oral malignant and premalignant lesions, though.
Ooh, nice segue. Well done.
I didn't really. Mouths are gross, and I suck at them. But I need to be better. So this is a CertLink article. So if you use CertLink to maintain your certification, you might see this. And it's a CME article out of the JAD, and it's called Premalignant and Malignant Oral Mucosal Lesions, Clinical and Pathological Findings. Authors include Mayram Maimon and Neelam Vashi from Boston and from Denver. So having read this article, I think sort of from a bird's eye view, this mouth that we've heard about isn't much different than the skin when it comes to what you could worry about. So if something is new or changing in the mouth, just like on the skin, you probably want to biopsy it, and then the biopsy results can help direct management. This article goes into some good detail about the nature and the clinical appearance of the various malignant and premalignant lesions that can show up, but all of that seems to me less important than just knowing when to biopsy, which, just like on the skin, is new or changing. One other important point is for malignancies in the mouth, an extremely important factor in prognosis is early diagnosis. So perhaps I should be more aggressive in biopsying the mouth. On the other hand, biopsies in the mouth are scary. And I don't exactly know how to do it, except, do a little shave, maybe punch and put in some fast gut or something. If it's too far back, then I have to go have them see somebody else. Maybe we need to review an article to discuss various biopsy techniques, especially for our listeners that might not have access to somebody else, a dentist, an oral surgeon, or an ENT doctor who could potentially help out in a timely fashion. And similarly, such multidisciplinary colleagues should treat proven cases of malignancy urgently. So if you do biopsy and it comes back as malignant, you want to get them treated real quick. So all of that said, here are some specific lesions discussed in this article. I'm going to go through them fairly quickly, again, because I think the most important thing is just go ahead and biopsy. So the premalignant lesions include leukoplakia, one of my many nicknames. This is a whitish or sort of whitish patches that, unlike thrush, do not rub away. They're associated with smoking, betel nuts, and alcohol, which also means they are associated with men and older age. They have a really small chance of malignant transformation, about 2 to 3%. Erythroplakia is kind of similar, but it's pinkish reddish and it has a much higher risk of malignant transformation, about 50%. There's this funny thing called proliferative verrucous leukoplakia, which looks warty and leukoplakic, as you might guess based on the name. It's multifocal, and it is slow growing, like over many years. Tends to affect older women. Malignant transformation in 60 to 100%.
Woof.
100% is kind of a lot.
Yeah.
Oral lichen planus. Remember Wickham's striae. This is considered premalignant because overall there's about a 1% chance that it could transform into a malignancy. Higher risk for erosive erythematous and atrophic subtypes. You want to treat oral lichen planus with something like topical steroids. If that doesn't work, you can consider intralesional steroids, calcineurin inhibitors, systemic steroids, immunosuppressants. Pathophysiology of lichen planus is still not really figured out, but is, quote, thought to be an autocytotoxic T-cell mediated immune response to basal keratinocytes. And if you have a patient who has just cutaneous LP, look in their mouth, they got a 60% chance of having it in there too. It's most common in women aged 30 to 60. Differential diagnosis, so things that can look like oral lichen planus include lichenoid drug reactions and then lichenoid mucositis or dermatitis. They are allergic to their dental filling or whatever. Getting a biopsy with DIF can help. Malignancies in the mouth. Oral squamous cell carcinoma is the most common. It kind of looks like you might expect a squame to look. It can also look like leukoplakia or erythroplakia. It's associated with smoking, alcohol, and men, as well as with sun, radiation, systemic disease, HPV, and STDs. Doesn't really have a great prognosis, especially if caught late, and half of them show up on the tongue. The 5-year survival rate is 55%. Oral melanoma is rare, but it's really bad. Of course, catch it early for best prognosis, like any of these, but it still ain't good. It's most common in white populations in a 2-to-1 ratio versus cutaneous melanoma, which is more common in white populations by a 5-to-20 ratio. Tends to show up in around the 5th decade, so I've got to start watching out. I think you do too, Michelle, not to out you or anything. It's thought that about a third of these oral melanomas arise from pre-existing pigmented lesions. 10 to 30% are amelanotic, which is especially terrifying. And from a genetic standpoint, this is probably bellworthy, they generally don't have the BRAF mutations that you can see in cutaneous melanoma, but about 40% have c-KIT mutations. So look in the mouth. If you seek it, maybe you will find it.
Well done.
Therapy for oral melanoma is not as well established as in cutaneous melanoma, but the newer targeted anti-neoplastic agents do look promising. However, 5-year survival rate in early tumors is 20%, and in advanced tumors it is 0%. Doesn't get much worse than that. Oral verrucous carcinoma, some other things, sometimes associated with high-risk HPV type 16 and 18, also associated with smoking, alcohol, and beetle nuts. Again, stop chewing those things. Talking to you, Michelle. It's locally aggressive, but usually doesn't metastasize. Kind of looks warty, like you might guess from its name. And then there's 2 salivary gland tumors. There's one called adenoid cystic carcinoma. It's a firm bump around the salivary glands. Remember, the biggest salivary gland is the parotid gland, so I think just based on the odds, that's where a lot of these are going to show up around the parotid gland. This one is aggressive. It shows up in middle-aged adults. 5-year survival is 85%. And then mucoepidermoid carcinoma, salivary glands as well, 84% in the parotid. Painless, fixed, and rubbery, like we think for malignancies in general. Can be pinkish, can resemble a vascular lesion or mucosal, so beware. Mucosals and vascular lesions are usually soft, though, and this one's sort of fixed and rubbery. Shows up in kids and young adults. 5-year survival also about the same, 82%. So that was a really quick rattling off of all of these things. Look for funny things in the mouth, especially around the parotid gland, especially on the tongue. Biopsy them if you see them.
It's like, smoke them if you got them, biopsy them if you see them.
Yeah, don't smoke them, and you won't need to biopsy them.
Malignant leukophakia.
Well, thanks for joining us today, friends. That's all we have time for.